It's a pleasure to give an introduction to uveal melanoma today. Eye tumours can occur anywhere in or around the eye, in many of the tissues, in the orbit, in the eyelids, the conjunctiva or the uveal tract, and in other tissues in the eye, the retina, the retinal pigment epithelium, and then in the vitreoretinal space as well. The uveal tract comprises the choroid, the ciliary body, and the iris. So the iris is here, the ciliary body is here, and then the lining underneath the retina is the choroid. And so tumours occurring in this location are within the uveal tract, in the lining of the eye, on the inside of the eye. Very commonly found is a mole in the eye, or a choroidal nevus. It is occurring in about 10% of the Caucasian population, and it arises from the melanocytes of the choroidal stroma. So here is such an example. You can see a pigmented, slightly elevated lump. On ultrasound, it's only 1.5 millimeters. So we take a photograph of the eye for the records, we do an ultrasound scan as a baseline, and then we observe these. And if growth is documented, then we would treat the lesion as a melanoma. So here is the same case 6 years later, and you can see that it looks very different, that this nodule has formed from the nevus. And when we do the ultrasound, it is now this mushroom shape, and this is a melanoma arising from a choroidal nevus. And there are several management options. Laser is not really done for this configuration. Radiotherapy mostly, and there are different ways of giving radiotherapy, and occasionally enucleation, that is removal of the eye, becomes necessary. Moles in the eye, or nevi, are very common. But melanoma is relatively rare, and Dr. Singh and colleagues a few years ago worked out that the risk of a mole changing into a melanoma occurred in approximately 1 in 8,845. So although 10% or so of the population might have a mole in the eye, the numbers developing uveal melanoma are quite low. So it's about 500 cases a year in the whole country in the UK. You can have suspicious moles, moles that have some features that might indicate a malignancy, and it can be hard to tell between a suspicious mole versus a melanoma. And these are the kind of things that we would look for. So thickness of the mole more than 2 millimeters on an ultrasound, if there's fluid under the retina, if there are symptoms such as flashing lights or part of the vision is missing, if lipofuscin, orange pigment develops on the surface, if there is hollowness on the ultrasound signal, and then if the diameter is more than 5 millimeters, either when we look in the eye or on photography. These are all indicators. And these are very important because, unlike cutaneous melanoma, it is not usual practice or even possible in the majority of cases to take a biopsy in order to make a diagnosis. The diagnosis in the vast majority of cases will be clinical with some tests such as ultrasound or optical coherence tomography or OCT scan of the eye and so on. There is an alternative way of judging the nature of the nevus or mole, known as the mole score, which Bertil D'Amato, who's been working in our department, has recently published. And here we're looking for the mushroom shape, orange pigmentation, large size, enlargement on serial follow-up, and subretinal fluid developing. And on each feature we give a score and give a total score, low score being just moles. An intermediate score can indicate a suspicious mole, and then a higher score indicates melanoma. So melanomas can look like this. They can be pigmented, they can be pale, they comprise, uveal melanoma comprises less than 5% of all melanomas. The rest are cutaneous in the large majority. And out of the eye melanomas, choroidal is the largest proportion. The incidence is 5 to 10 cases per million of population. And it's a very similar incidence in Europe and the US compared to Australia and New Zealand, where there is much, much higher UV light exposure. Males are slightly more commonly affected than females, and overall small numbers generally of melanoma. The risk factors, host factors are things such as race. It's more common in Caucasians than Africans. The textbook description is light skin color, blonde hair, blue eyes, but in actual fact it occurs across the board. There are conditions where there is excess pigmentation due to the presence of more melanocytes called nevus ovota, if there's pigmentation of the eyelid as well, or ocular melanocytosis if only the eye is involved. Other conditions, neurofibromatosis type 1, the BAP1 tumor disposition syndrome, and then familial atypical mole and melanoma syndrome also can lead to uveal melanoma. In terms of environmental factors, sunlight is not thought to be significant for choroidal melanoma. It may be implicated in iris melanoma, but not in choroidal. And occupation, there's very inconsistent evidence, which is not surprising given the difficulty in studying a rare disease. This is American data, again from Dr. Singh's work, looking at the incidence per million of population from 1973 to 1997, and you can see a fairly steady line for the presence of, or the incidence of, uveal melanoma per million of the American population. If you did the same graph for cutaneous melanoma, it would be very different to this. It would rise exponentially. So very different disease in terms of its biology, though it shares a common name. So what are the treatments? Well, it depends on the size, small, medium or large. Small ones, we might observe them sometimes. Laser, different types of laser has been tried, but mostly it's the same as medium melanoma. The vast majority of medium melanomas are treated by some form of radiation. This is plaque brachytherapy, a little disc of radiation, which is sutured to the eyeball for the right number of days and hours. Very common treatment. Proton beam radiotherapy is depicted here, where radiation is beamed from a device from the front of the eye to the back of the eye. Stereotactic radiosurgery has also been done, which is similar to the proton. And then surgical resection can be done. Sometimes laser is added in. For large melanomas, generally speaking, most are enucleated, though some can be treated with proton beam or plaque brachytherapy as well. Uveal melanoma can metastasize mainly to the liver, sometimes to the lung. We normally carry out some staging imaging on presentation, a liver ultrasound and a chest x-ray, but some centers will do a PET CT scan or an MRI scan. Screening after the treatment is controversial. We used to do liver function blood tests, but that has really fallen out of favor. And now liver imaging using non-ionizing radiation can be ultrasound, can be MRI, and so on. Usually the preserve of a melanoma oncologist. Mortality is, the headline figure is up to 50% at 5 years, but actually that is dependent on many factors, which include clinical factors, histopathological factors, and genetic factors. And I'll just tell you a little bit about genetics. And this is genetics within the tumor. It's not the kind of genetics that you generally pass through to your family. This graph is work from Sheffield, looking at loss of chromosome 3 and duplication of chromosome 8q. And you can see this is the chromosome 3 data. If you had favorable genetics, then survival was good. But if you had unfavorable genetics, then survival was poor. More recent studies show that there are three classes of melanoma: class 1A, a low metastatic risk; class 1B, a longer term metastatic risk; and class 2, which is a more immediate, higher metastatic risk. And the implicated genes are GNAQ, GNA11, BAP1, and PRAME. So to summarize then, uveal melanoma is a rare type of melanoma. Sometimes it can be hard to tell between a very suspicious nevus or a small melanoma. Mostly these are treated by radiotherapy, though there are other treatments as well. And sometimes enucleation becomes necessary, either if the other treatments haven't worked, or the complications are high from other treatments, or the tumor is just too big to treat with other means. And the prognosis depends on many factors. Thank you.
Hello and welcome everybody. It's a real shame that due to the COVID pandemic, we aren't able to meet face to face, as I think that's always a better way of delivering these talks. But this year, it'll have to be done electronically by means of a PowerPoint presentation. For those of you who haven't met me, that's my photograph. The original picture has my wife standing next to me in a selfie. So if you do ever get to meet her, please don't tell her I cropped her out of the image. I thought we should really start with just talking about a few of the common pigmented conjunctival lesions. Melanoma is the least likely of diagnosis in this category. Much more common in the population is complexion-related melanosis. And we see this in people from pigmented racial groups, such as South Asians, Afro-Caribbeans. This kind of pigmentation is often bilateral. You see areas of flat, rather bland pigmentation on the ocular surface in both eyes. This is a benign condition, and as a rule, I tend to avoid surgery where much as possible. Some of the pigmented races are more prone to develop significant scarring after surgery. And I wouldn't want a patient to develop a potential scar that was actually worse than their original condition. Reasonably common also are conjunctival nevi, or moles. These often present in the first or second decade of life. Usually they're quite discrete, variably pigmented lesions on the surface of the eye, maybe slightly elevated. They often have clear cysts within them. That is a good sign. Usually it's found on the bulbar conjunctiva, so that is the lining of the eye over the white part of the actual eyeball. And it is calculated that there is about a 1% lifetime risk of a conjunctival mole transforming into a melanoma. So usually I wouldn't advise any specific treatment other than just observation. If the lesion looks a little suspicious or there is evidence of growth, then I would probably opt for surgery by means of an excision biopsy, and then depending on the result, whether we would have to give anything extra, such as radiotherapy or chemotherapy. Here are some examples of common nevi. So the first picture on the left shows a rather almost gelatinous see-through lesion with very little pigmentation. The middle photograph shows a similar nevus, but here we have more scattered areas of pigmentation, but around them, though it's not always easy to see, there are small clear cysts. Importantly, there are no feeder vessels, so these are dilated blood vessels that seem to be feeding a growing tumour. The picture on the right looks more dramatic and maybe a little bit more worrisome. The pigmentation is sort of more confluent and it's darker, but the patient is of a pigmented race. This was actually excised because of the concern by the patient and proved to be a benign nevus, probably on a background of complexion-related melanosis. Here is a case of a patient who has rather bland nevus on the surface of the right eye. The first photograph shows the scattered pigmentation, some pale cysts, and a fairly flat shape. The second photo shows that over time it's probably got a little bit darker, but again, nothing too concerning. It was only a few years later that the patient returned with this dark, elevated, thickened nodule at the same spot in that eye. And you can see these dilated feeder blood vessels. The patient went on to have surgery. And that was the result after the operation. A very important diagnosis is one of a condition called primary acquired melanosis. We call this PAM for short. Technically, this is a benign condition, but the importance of it is that this increases the chance for a patient to develop conjunctival melanoma if you have PAM. It's almost always unilateral in that it affects one eye. I don't understand why that is, but I've never seen it in two eyes at the same time, nor two eyes in one patient. If we are concerned about primary acquired melanosis, we do want to have an initial biopsy so we can get a pathology report, and particularly to look for the degree of atypia. And that is how many atypical cells are present in the PAM. And this is graded by the pathologist as either having no atypical cells, mild, moderate, up to severe atypia. PAM is a condition that usually starts in middle-aged adults, particularly those of pale skin groups. And if you watch these patients over years and decades, as we often do, you find the pigmentation will come and go. New areas become prominent over years and old areas fade away. And although fairly rare, one can develop sine pigmento disease, which means without pigmentation. So this is pale areas on the surface, and that's difficult to know what is PAM and what isn't. And we know that PAM is in the outer lining of the eye. So if you move it with a cotton bud, you can see that the pigment moves with the outer lining and it's not actually stuck on the eyeball. So the picture on the top right shows a patient with these patches of pigmentation on the surface. I always say to patients, it looks as if someone has sprinkled pepper on the surface of the eye, and that's normally PAM. The bottom right photo shows a patient with non-pigmented PAM, in which a more suspicious nodule has actually grown. Treating PAM is open to little controversy, as it depends how aggressively should you treat the underlying condition against the risks of therapy. At Moorfields, we tend to observe patients where the PAM is relatively small and flat. We always prefer to perform an initial biopsy, just so we know that it is primary acquired melanosis and what degree of atypia. If there's areas that are looking a little bit more suspicious, we may decide to perform surgery earlier. And sometimes we perform a mapping biopsy, where we take multiple samples across the surface of the eyeball, so we can look at all the different areas to see if there's anything suspicious. But as a rule, any part that looks thickened, lumpy, or has feeder vessels, I treat that as a potential melanoma and would definitely remove it. We usually will combine surgery with cryotherapy, which is freezing treatment to reduce the risk of local recurrence, and sometimes with topical mitomycin C chemotherapy, which is given as an eye drop. This brings us to conjunctival melanoma itself. This is a cancerous growth that are derived from the same pigment cells or melanocytes that are found on the surface of the eye. It has some interesting statistics. It is said to account for about 2% of all eye tumours, about 5% of all melanomas in and around the eye, and about 1/4% of all melanomas in the body. And primary acquired melanosis accounts for really 1/2 to 3/4 of all conjunctival melanomas. And a lot of those, maybe up to half, are actually in patients with severe atypia. And that's why it's important for us to know if you have PAM and the degree of atypia. Under 5% are thought to derive from pre-existing nevi or moles, and around 15 to 25% are probably de novo, which means they have grown without any underlying reason. Melanomas occur in sort of middle and late middle age onwards, with a median age of 62. Anatomically, the majority occur in the limbus, which is the area around the cornea, the window of the eye. Less commonly on the bulbar surface, which is over the eyeball itself. Then the palpebral conjunctiva, which is the lining of the inside of your upper and lower eyelid. And last and least commonly in the fornix, which is down in the corners where the conjunctiva has a fold. Melanomas are usually pigmented, so they're brown and black or tan in colour. They very occasionally can be amelanotic without colour. They usually have quite prominent feeder vessels, and you may see areas of primary acquired melanosis on the surface of the eye otherwise. So here are a few examples. If you look at the top left photograph, you might think that's just a small mole. It doesn't look particularly raised. The feeder vessels are not very prominent. But it's interesting that the pigmentation is creeping onto the surface of the cornea, and that is quite unusual for a mole. This was excised and in fact proved to be a melanoma. The top right shows a rather more worrying looking lesion with dilated vessels and a lumpy nodular component. And in the bottom photograph, even more so, where this mass is actually growing forwards on the surface of the eye and interfering with the patient blinking. Here's another patient with more diffuse areas of pigmentation on the surface of the eye, on the outer side. in which there is a solid, almost black mass with the big dilated blood vessels. So we treat these by surgical excision. We want to give a good safety margin around the lesion, often 3 or 4 millimeters, and then we apply cryotherapy or freezing treatment to the tissue around the cut edges, and that's to reduce the risk of local recurrences. Then you have to reconstruct the area that's been removed, and you might require an amniotic membrane graft to allow the tissue to heal. And then depending what the pathologist finds, you might require some local radiotherapy or chemotherapy. We're fortunate in London to have a strontium radiotherapy applicator, which is the small disc with a long handle. The disc is radioactive and can be placed onto the surface of the eye just with local anesthetic drops to give radiotherapy to that small area. And lastly, some patients may be amenable to sentinel lymph node biopsy. This is a technique where, following your operation, we aim to inject a coloured low-dose radioactive dye at the operation site and see if we can track where the dye travels to the local lymph nodes. And if possible, we may be able to have a small operation to remove the lymph node and see if there's any evidence of tumour cells within it. It is a little controversial in the success rate and what it really means for the patient. So we do them on selected cases, particularly those who have got quite large tumours at presentation. Thank you very much.